And I'm involved in clinical research of Sturge-Weber syndrome in the past maybe 20 years since I'm here, mostly in the imaging component. So you can see on my title side, I always like to show some dramatic images. On the right side, you can see a PET scan and an MRI of some typical findings of Sturge-Weber. But these are coming from partly clinical and partly from our clinical research studies, which we have been doing. And I like to right now just share some thoughts about clinical research. Why are we doing it? And maybe some guide how to get involved in research, what's going behind the scenes, what kind of questions you can ask if you are thinking of getting involved, and how to do that. So hopefully that would be a little bit helpful. So I think it's important to realize that Sturge-Weber syndrome is one of up to 7,000 rare diseases, and they're all competing for attention, and they're all struggling with the same issues that we have. That we have a lot of unmet needs that Dr. Loeb talked about, and there's a limited funding, obviously. So the rare diseases actually, as a whole, is a big chunk. It affects estimated 25 to 30 million people in the United States. So as a whole, rare disease is actually the most common disease of all. And it's defined as 1 out of 1,500 affected people. So in the US, any disease that affects less than 200,000 people is a rare disease, and definitely Sturge-Weber is one of them. So what are the issues we are against? Is basically many of the rare diseases, maybe not that much for Sturge-Weber, but sometimes, yes, the patients are not diagnosed properly, or they are diagnosed late, or they are mistreated because most of the physicians are not familiar with 6,000 or 7,000 different rare disorders. So that's why it's important to get to a center like one of the clinical care centers of the Sturge-Weber Foundation to actually see some experts who have seen a lot of patients and have a lot of experience. But for research, it's actually hard to collect big enough data, and that's why this comprehensive database that we try to build through the BVMC grant is really critical. It's of course not easy to get funding, partly because most of the researchers have limited knowledge. The sample sizes in single center studies is small, and there's a lot of competition, as I mentioned. On the other hand, usually it's not profitable for drug companies to develop new drugs specifically to one rare disease. So it's very common to try to repurpose existing drugs. It's more feasible, it's less costly, but sometimes there are some serendipitous discoveries that help some drugs to make it useful for rare disease like Sturge-Weber syndrome. But for all these reasons, most rare diseases do not have FDA-approved specific treatments. So for example, for the neurocognitive symptoms, these are all targets for clinical research. So for example, focal seizures that affects the majority of people with Sturge-Weber syndrome. Usually we use the regular anti-epileptic drugs that are available for any other seizure types or seizure etiologies without really knowing whether or not they work the best for Sturge-Weber syndrome, or which has some advantage from the point of the underlying pathophysiology of the disease. Also, many people are affected by the stroke-like episodes. And as Dr. Loeb mentioned, aspirin, does it affect it? Does it prevent it? We have some interesting, mostly retrospective studies published. There's no okay, I'm getting some noise. Hopefully it will go away. And the learning disability, cognitive impairment, and behavioral issues, which again affects a large percentage of patients, are the current available options useful, or can we get something new, something that really is going to change the overall course of the disease and the outcome? And same for migraine headache, which is more common in Sturge-Weber, especially in older children and adults. What are the best available options? We need some prospective studies. So these are all just for neurological symptoms. There are a lot of questions that we can target and answer with clinical research. And I think it's important to know when you are considering getting involved into research that by the time you see a study that is open for you, it usually, it already underwent a lot of different levels of reviews, and probably the investigators work on that already for months or years just to get to open for enrollment. So for example, any study undergoes a rigorous scientific review, usually multiple times. And then there's a human subject safety review, and especially for clinical studies, it will be mostly registered as a clinical trial. So the scientific reviews depend on the actual reviewer and sponsor, what kind of reviews they provide. The biggest funder is the federal funding in the United States, the NIH, that usually likes to fund large definitive studies. It has millions of dollars to give out, but it is very competitive. So usually when we submit a grant, we have less than 20% success rate. So usually we struggle to send it and revise it and resend it, and it takes years to actually get this funding. They like strong innovation, and they also fund basic and clinical studies. And there are smaller funds available from the corporate world. They like to fund smaller studies. They tend to focus on drug safety or efficacy studies with some limited time and funding, but they are very important because NIH probably will not fund these kind of studies. And of course, the foundations are very important, like the Sturge-Weber Foundation, to find pilot studies and also invest in some innovative new research, and especially to foster collaboration to that we actually, through the foundation, we met with each other, with the different centers, and came to collaborate on different projects. And once the funding is available, these protocols usually undergo a human safety review by the local institutional review boards, which is part of the universities usually. They also look at the protocol very rigorously. They weigh the risk and benefit ratio. Is it balanced? They approve it, and then they monitor the study safety. Usually there's at least annual reviews and audits. So that way you can make sure that the protocol that's presented to you is safe for you. It's not gonna be any unreasonable risks for that. And finally, when this is done, now it's a requirement for most studies to get registered on clinicaltrials.gov. This is the website that basically available to anyone in the world. And it ensures, again, they review the trial design, that it's reasonable, and they make sure that it's transparent and there's public access. So that's very important to that, because especially for federally funded studies, it's a requirement to make all the data, all the findings available to anyone in the world, basically. So this is the basic structure. Dr. Loeb already talked about the Brain Vascular Malformation Consortium. That's one of 23 active consortia of the Rare Diseases Clinical Research Network, managed by the NIH, and also the clinicaltrials.gov under the NIH that has all these studies. And I like to show us few slides if you are interested in getting involved, how you actually find the right study for you for Sturge-Weber syndrome, specifically to your issues and problems and ages and so on. So if you go to the website, clinicaltrials.gov, then this is the first page that you will see. It tells you that there are almost 400,000 research studies registered currently from 220 countries, not just the US, but any country can register. And on the right side, I circled this area. So this is where you find your study that you are interested. So if you go down, you can see condition or disease. So if you punch in, for example, just Sturge-Weber syndrome, you will see how many studies have their focus on the Sturge-Weber syndrome. But this is true for any other disease, any other condition. You can punch in and see what's available initially in a tabulated form. So this is what you will find right now. You will find 21 studies. And this is the first page. This is the first four that pops up. And I just circled two of them because we are involved in this. So one of them, number two, is the imaging studies that we are conducting at Wayne State University in Detroit. And the other one is actually the large multi-center study that Dr. Loeb talked about. It's also registered on clinicaltrials.gov. You can see on the far right side, there are the locations for each study. So you can tell where is it going on. For the multi-center study, the main site is UCSF in San Francisco, but it's part of a larger study. So they mostly are involved in other vascular malformations. And the University of Illinois with Dr. Loeb is the lead site for the Sturge-Weber. And there are 5 other sites, Kennedy Krieger, Wayne State, and some others, as he mentioned, who are actually doing the Sturge-Weber part of the study. You can also see in the table the intervention. So it tells you right away whether it's a drug study or a diagnostic test or something else. And I will show a few more examples from our study, what kind of information you can actually see if you go click on one of those studies that you would be interested in. Of course, there are some other studies. You can see the second page. The status of some of these studies are not recruiting. So what you may be interested in mostly is the ones which are open. Those are the green studies that are recruiting. Some of them not yet recruiting, but already registered, so they're ready to go. But other studies which are completed or terminated, these are past studies. You can, if you click on them, you would see probably some results which you may be interested, but to see if it succeeded or failed, other publications and so on. But if they are already completed, they are not available for enrollment. So if you go on, for example, click on our study, the next page will tell you very briefly. On the bottom, you see a few lines. Basically, it gives you a brief summary, just a brief description of what is the study about. So that tells you what is being done and why is it being done on what kind of subjects. So that helps you to decide whether or not you want to go further and explore the details of the study. And if yes, and you go to the next page, it will tell you who are the participants, what is the time frame of the study, and also in another page, if you click further, you would see what kind of interventions are being done. An intervention doesn't mean a treatment. It could be a diagnostic intervention. For example, here, what is listed is a diagnostic intervention of brain MRI. And this is some advanced brain MRI that is developing, and it's still, some of them is still not part of the clinical routine, but it's being developed based on the experience that we had in the past 15 years from our studies to get better and better MRIs to see more details specifically of the calcification that Dr. Loeb mentioned, or the fine details of the blood vessel abnormalities, high resolution, and also some other things like the brain connectivity, how the different brain pathways are rerouted, and how does it affect the neurocognitive functioning and the outcome of the disease. And that's why we also do neuropsychology testing for our patients in order to be able to compare it with the MRI, and also to look at it longitudinally to see how it changes over time and how the brain changes and the neurocognitive changes correlate with each other, to see what are the brain abnormalities that really will predict what kind of neurocognitive or behavioral abnormalities will develop over time. So these are the things that you could see. And if you, based on this, you are interested in the study, in the next page, it will tell you the eligibility. So you can kind of assess whether or not, if you are interested, you are eligible. So it shows you the time frame. Right now, for example, our study, which was previously a pediatric study, is now involving young adults. So we are able to test those who are young adults up to 30 years of age, and including those who we enrolled before. We had children who we scanned 15 years ago, and now they came back and got scanned and tested again. And this is really, really interesting to see how the brain on the long term changes in the disease, what are the variations, and how is it related to the neurocognitive outcome at age 20, 25, or 30. This is something that never been done before, so we are very excited. about that. And it shows some other inclusion-exclusion criteria. So you are able to evaluate whether or not you want to contact the investigators and get enrolled. So basically, when you see this information, you can ask some questions. Some of them are probably answered more or less based on the clinicaltrials.gov website. What is the purpose of the study? Am I or is my child eligible for participation? What are the main study procedures? But of course, you may have more questions that you need to ask. You need to contact the study investigators, which is also listed on this website as well as on the BVMC website with the BVMC study. And you can discuss then on the phone or by email or personally, what are the potential risks and what is the benefits? Are there direct versus indirect benefit for me? How long is the participation? Is it one time or is it longitudinal? If I go there, how long does it take to complete a session? And also, how do I get the study results? Both my own result and the result of this overall study eventually. That may be also important to get a report from your MRI or neurocognitive or other testing. And of course, is the study free, or am I compensated for time or travel costs? This could be also important. Again, rare diseases, if you have to travel, it may cost you. Our study, luckily, by the NIH, can reimburse study travel costs. So we can recruit from anywhere in the US right now, and that's very fortunate. So once you decide that you are really interested in the study, you will be handed a consent form, and that's a multiple page form that you will need to review and approve and then sign. And basically the major elements of any consent form that you will see are listed here. Beyond the PI, contact info and funding source, it will have to tell you what is the study purpose. It will again explain in detail what are the procedures, are there any risks, and what are the potential benefits, are you compensated, and also there's some confidentiality and voluntary participation or withdrawal portion that you have to go through and approve. And usually there's a page with HIPAA. Basically it lists the personal data to be collected for the study purposes, and also has to list the entities with whom the data can be shared, not just the sponsor, but the local IRB, NIH, or anything else. So you have to be aware of that, and you can ask any questions to make sure that your data are safe. And then eventually you sign the consent form. That's the moment when you are enrolled and you can undergo the studies. So there are some specific considerations with children. Many of the participants are children or the mentally impaired. If the participant is less than 18 years of age or mentally impaired and under a guardian, then the consent form is actually signed by the parents or the legal guardians. But if the child is between 13 and 18, they will given a written assent form. And this is basically a simplified consent form, usually much shorter, but has the same basic elements in a very lay language to explain what we like to do, and the child has to sign it separately. And if it's below 13, then usually we just get oral assent when the parent is present. So we have to ask the child if they agree, they understand what's going on, and they have the chance to discuss, or if they have any questions, and they can even decline participations if they want. So that's in very briefly what's going on behind the scenes. And eventually, if you get enrolled, you get scans like this. And the title of this slide is Expect the Unexpected. And I'd like to show just one example that although we usually have a very well defined aim and some hypothesis in our head based on our previous experience and the science, what we expect to be the result, sometimes get some very unexpected findings, which are very important and very exciting, and can give us a very new direction, what we haven't thought before, actually. And this is an example. And I like to show a few images because it's imaging. I thought it's good to show some images of how it looks like. So this was an 8-month-old girl that who had seizures and had get enrolled about 1 month after the seizure started. And we did an MRI. You can see on the left side a few MRI planes, and you see these blue blood vessels highlighted. Those are some abnormal enlarged blood vessels in the brain, white matter. You see the other side, the purple is the normal, how it looks. So there are more and enlarged blood vessels also in the lower plane. So this is done with SWI, which stands for susceptibility weighted imaging. And this is a relatively novel MRI that 10, 15 years ago was completely a research tool, and now made a way to the clinical side. So any good Sturge-Weber MRI acquisition should contain SWI, not just because it shows these deep veins in exquisite sensitivity. It actually is very good to see classifications that Dr. Loeb talked about. But on top of that, we had a PET scan. On the right side, you see this colorful picture. So this side of the brain is normal. So where you see all this yellow and red, basically this shows the brain metabolism. How is the metabolic state of the brain on the hemisphere? On one side is very good, the unaffected side. There's a lot of glucose going in there. It's metabolically very healthy. But on the other side, it's mostly shut down. You can see hardly anything. A little bit of green means that it's a very low level metabolism. So obviously it's very concerning. It means that hemisphere is kind of in a big trouble already at 8 months of age, just a month after the first seizure. So this is a longitudinal study, and what we expected that this hemisphere that we have seen some other children before, that will be completely shut down in a year or two, and basically then the hope is that some of the functions will transfer to the good hemisphere through brain plasticity, which actually is a great thing in young children, that it happens very early. Much of the function can just go to the other side and reorganize, although there will be some motor abnormalities, even if it's just one-sided, and maybe some visual dysfunction. So the child went home. She got some anti-epileptic medication, aspirin, and came back at 29 months of age. And this was the unexpected. What we have seen, first of all, on the MRI, you see all this blue. She had much more blood vessels in the deep brain. So it expanded greatly during this 20 months period. But more importantly, the PET scan actually showed a great recovery in this hemisphere. So it looked like that the one that we saw in 8 months was a mostly functional abnormality. And somehow, as these deep veins expanded, metabolism was able to recover. So basically, it gave us a lot of excitement and some new questions. So basically, it supported the notion that these deep medullary veins, how we call it, these deep medullary veins, are probably in many cases play a compensatory role and help the venous blood to channel to the deep venous system to help out the surface veins, which are the leptomeningeal malformation and are not able to function properly. But somehow these deep veins, which are normally in the brain, but they are very rudimentary and have not much role, they expand and start to create a brand new network in the deep brain and kind of salvage the brain from a permanent severe damage. So these are the questions that after that we started to ask, how common is this expansion? And since then we have seen a few other children where there was some signs, although not the dramatic of this expansion. It depends on how you time the MRI, because probably it happens very early on during the disease process. Do these veins provide effective compensatory venous blood drainage? And most importantly, if there's a good compensation, would this really lead to a better neurocognitive outcome? And the ultimate question would be also could we somehow facilitate this early deep venous expansion? Or could we, if they expand, could we prevent that they get obliterated? And because we have seen some cases that these deep veins were there, but probably there was not much blood for there. So they probably got some blood clots in them at some point, and they didn't function as well as in this child. But this child was really lucky, and we had a few more who had similar similar in the brain, who do very well. So this child has been doing well and mostly seizure-free and developing well, despite that the right hemisphere is affected by Sturge-Weber. These deep veins probably helped out a lot. So this is the way, kind of discovery, serendipitous discovery that we did not expect, but really led us to ask some new questions and design our study to really focus on these deep veins. And we have a SWI that can look at these veins and can see longitudinally how these veins expand and how does it affect the ultimate outcome. So this is one of the questions that we are working on right now. So again, I need to emphasize that Dr. Loeb also was highlighting that anybody who is interested, just consider participating in the clinical research. Look for opportunities online. There's a lot of available, both on clinicaltrials.gov and the BVMC and the Sturge-Weber Foundation website. I think it's very helpful to connect with other families who already participated in the research and have some experience and can tell what is it like and how did it go. Especially clinical research often has some direct benefit for the participants, but it's not guaranteed, of course. That's why it's research, because we don't know what's going to happen. But definitely, almost 100%, there will be indirect benefits for the community to learn about disease. And as I illustrated with this case, even a single participant sometimes can make a big difference. We can find something that we didn't expect that can lead to new findings and some really new and exciting research directions. So that's I think, very important. So because the ultimate goal is, of course, is to improve clinical care and improve outcomes. So that's why we are doing it, and that's where I